everyone, good evening. I am here on PrepLadder and all our questions of the FMG examination that was conducted yesterday. I'm sure and I'm confident that all of you have done really well. Considering the questions that were asked in ENT, I am absolutely hopeful that all of you would have got all the questions absolutely right. If I'm audible and visible to all of you, kindly give me a quick confirmation so that I know that the relay is fine and we can go ahead with the class. Okay, great. So I think the audio visual seems to be fine. We're going to quickly start the session. Before we start the session, I'd like to give a quick disclaimer that the questions discussed in this PPT are basically recall based, and the motive here of this live session is to get the question and answers to the students who appeared so that they have an approximate idea of how they did and how they fared well in their examinations. But the actual questions will be put up in the app after we have discussed and after we've worked out on the actual questions and the language of the questions with different students, because this was just conducted yesterday. The best that we could get is what we are putting up forward, but yes, the final questions will be put up in the app very soon in a similar language and similar options that were asked in the examination. Okay, so let's begin with the ENT questions. The first question that I'd like to discuss here is, which of the following is true regarding the external nose? It is made up of bony 1/3 and cartilaginous 2/3, bony 2/3 and cartilaginous 1/3, bony half and cartilaginous half, bony 1/3 and cartilaginous 1/3. So if you see, the external nose is one of the first topics that we begin when we start the anatomy of the nose. Like, we start with the external nose, then we go to the internal nose, we learn the anatomy. But what I understood from the students when I discussed with few of the students last night is most students didn't pay attention to the word external nose. They thought, the striking thought that most students got in their head about this question was about septum. They started thinking about how much is the cartilaginous septum and how much is the bony septum. This is what some of the students told me, that they got confused in the examination. But the question was not about septum, the question was about external nose. So if we see the external nose anatomy, we know that the external nose is made up of a bony pyramid like this, and it is made up of a cartilaginous pyramid like this. So bony pyramid accounts for 1/3 of the external nose and cartilaginous pyramid accounts for 2/3 of the external nose. We learn that nasal bones form the bony pyramid as the major bone. So what you see here is the nasal bone, one on the right, one on the left. So we have got the bony part, which is 1/3, which is made up of paired bones, and we have got unpaired bones that form the bony pyramid. So in the paired bones, we have got the nasal bones and the ascending process of maxilla. So we have the nasal bone and the ascending process of maxilla that forms the paired bone. So this is your nasal bone and this is your ascending process of maxilla. So they are paired, one on the right, one on the left. And from above we have the frontal bone. So this frontal bone is the unpaired bone. So one unpaired bone is your frontal bone, and we have got two paired bones, which is the nasal bone and the ascending process of maxilla. The lower 2/3 is your cartilaginous pyramid. This lower 2/3 is made up of 3 paired cartilages. The 3 paired cartilages are upper lateral cartilage, lower lateral cartilage and sesamoid cartilage. So we have upper lateral cartilage, lower lateral cartilage and sesamoid cartilage, which are the 3 paired cartilage. One unpaired cartilage is your septum. So the one unpaired cartilage that we have is your septum. So I'll just open the nasal architecture so that you will be able to identify it even better. So you can see here the upper third of the nose is made up of nasal bones. So this is your paired nasal bone, one on the right and one on the left. From above you have the frontal bone. From the sides you have the ascending process of maxilla. So this forms your bony upper third of the nose. The lower third of the nose is formed by cartilaginous pyramid. So you can see this is your upper lateral cartilage, this is your lower lateral cartilage. Paired on both the sides you have upper and lower lateral cartilage. You have small sesamoid cartilage, and from below the unpaired cartilage is your septum. So now I am sure you are able to understand the bony pyramid and the cartilaginous pyramid of the nose. Even if you didn't know, even if you have not read it, it was advisable that you could just touch and see this much is bony 1/3 and lower 2/3 is cartilaginous. But having said that and done, in exam there is stress, you might have got missed or confused. It's okay, done is done. Now we will learn for forwards. Okay. So now let's go to the next question. I hope all of you got the answer right to the previous question. So the nose is formed by, external nose is formed by bony 1/3 and cartilaginous 2/3. That forms your correct answer. Let's go to the second question. The patient with Bell's palsy came with complaints of deviation of the face. The deviation is seen on which side? Same side upper part, same side lower part, opposite side upper part, opposite side lower part. Now there has been a little bit of discussion on this question when I talked to my students, because some students mentioned which part is affected, not deviated. Some students mentioned that the question was on which part is affected. Some students mentioned it is deviation, some mentioned affected. So I think this was a little bit of dicey thing that some students told this way, some students told that way. But having said that, we can discuss both. If the question was which part is affected, it is the same side lower part. So if we are talking about which part is affected, Bell's palsy is a LMN type of facial palsy. It is a lower motor neuron type of facial palsy. So we have the lower half of the face on the ipsilateral side getting affected. We know the forehead is getting bilateral innervation, so it is forehead sparing. So LMN type of facial palsy in Bell's palsy affects the ipsilateral side, so the same side, lower half. But the deviation will not be towards the same side. If the question was deviation, the deviation is towards the normal side. Why is the deviation towards normal side? Obviously one side muscles are not functional, they are paralyzed. The opposite side muscles are functional, so they pull the face towards the normal side. So deviation is towards the normal side, but the affected part is the same side. Okay. So I hope you get this answer right in your exam. Whether the question was affected or deviation, you should be able to understand and answer this question. Okay. Okay, Pickle, I'll use a thick pen for you. Yes, of course I'll do that. Let's go to the next question. A 16-year-old male presented with recurrent profuse bleeding from the nose. What would be the treatment plan for this patient? FNAC, biopsy, radiotherapy or surgical excision? Yes, so when we are talking about 16-year-old, so we are talking about 16-year-old male patient presenting to you with recurrent unprovoked profuse epistaxis. So if you have a patient who's 16-year-old male, recurrent unprovoked profuse epistaxis, you must have no answer in your mind. You should only and only think about one thing, which is juvenile nasopharyngeal angiofibroma. This juvenile nasopharyngeal angiofibroma is seen in juvenile age group. It is a tumor which we see exclusively in males, presenting to you with recurrent profuse epistaxis or bleeding from the nose. As the name suggests, angiofibroma. Angio means it is a very, very vascular tumor, and since it's a very, very vascular tumor, it bleeds excessively. Now, when it bleeds, why are we so much concerned about this profuse bleeding? Because the blood vessels that are present in these tumors are only endothelium lined. They do not have the muscularis layer. So since they do not have muscularis layer, what would happen when they bleed? They will bleed profusely and excessively. The blood vessels cannot contract, and once the blood vessels cannot contract, the bleeding won't stop immediately. This is why the patient presents to you with recurrent, unprovoked, profuse epistaxis. Now, if you see this tumor on endoscopic view, you would see that it is a vascular mass. It is a red vascular mass present in the nasopharynx. The most common site of origin of this tumor is from the sphenopalatine foramen. So the most common site of origin is the sphenopalatine foramen. Okay, and this tumor is known for local spread. So it is a locally invasive tumor. So it's a locally invasive tumor. Okay, so most common site of origin is sphenopalatine foramen. It's a locally invasive tumor. Now that we have learned that this tumor is having no muscularis layer, no smooth muscle layer, do you want to touch the tumor, probe the tumor, digitally palpate the tumor, take FNAC or biopsy? No. All of these are contraindicated. So what is contraindicated? FNAC, biopsy, probe test, digital palpation, all of these are contraindicated in a patient who is having angiofibroma. So all these are contraindicated. So in a patient who's presenting to you with angiofibroma, you will never do that. Now, is this a benign tumor or is this a malignant tumor? It is the benign tumor, and it is the most common benign tumor of the nasopharynx. So it is the most common benign tumor of the nasopharynx. So all these are additional MCQs that could be asked in your further examinations, and they are very important. So when we say about management of this condition, we have to always embolize the tumor, meaning if this is the tumor receives its blood supply mainly from the internal maxillary artery. So we block the blood supply of the tumor by embolizing. The tumor becomes avascular, and then you will surgically excise the tumor. So the treatment is embolization followed by surgical excision. So that is the treatment for patients with juvenile nasopharyngeal angiofibroma. FNAC and biopsy are absolutely contraindicated. It's a benign lesion, so radiotherapy has got no much role. It is only indicated in patients where the tumor is inoperable, or if there are multiple recurrences, then there is some role of radiotherapy. But the primary treatment is never ever radiotherapy. The primary treatment is always embolization followed by surgical excision. So I hope all of you got the important pointers of juvenile nasopharyngeal angiofibroma here. Let's go to the next question. A 2-year-old male child was brought to the emergency department. The child was having difficulty in speaking and breathing. An X-ray was performed and the image is given below. Which among the following is the best treatment for the following condition? Is it bronchoscopy? Is it tracheostomy? Is it esophagoscopy? Or is this Heimlich's maneuver? What should you do for this particular patient? They have given you 2 X-rays, one in an antero-posterior view and one you are seeing in a lateral view. So one you are seeing in an antero-posterior and one in a lateral view. Absolutely right, Amritansh, Lucifer, you're right. So in an antero-posterior view, you're able to see definitely there is a foreign body. You are able to appreciate that there is a foreign body, and this foreign body looks like a coin. You're able to appreciate. But can you appreciate that this is in the trachea or is this in the esophagus on the antero-posterior view? No, you cannot appreciate that. You will be able to appreciate whether this is on the in the trachea or in the esophagus only in a lateral view. So if you take a lateral view X-ray, please check the air column. the air column would appear black. So if you keep following the air column, this air column that you track is the air column leading to your larynx and from there to the trachea. Behind that would be your hypopharynx leading to the esophagus. So prevertebral, that soft tissue that you see, is the hypopharynx going to the esophagus. So this would be the pharynx going to the esophagus, and typically the foreign body is in the digestive tract, not in the airway tract. So even the worst situation, when you don't know the location also, at least just see, is it in the air column or the soft tissue column? If it is in the soft tissue column, it is in the digestive tract. So if it is in the digestive tract, what will you do? Obviously you cannot do a bronchoscopy or a tracheostomy because it is not obstructing the airway. So these options are easily ruled out because it's nowhere in the airway. The foreign body is in your esophagus. So you will have to do a esophagoscopy to remove the foreign body. Heimlich's maneuver is a maneuver done again whenever the foreign body is choking the airway. So whenever there is a foreign body choking the airway, you will do a Heimlich's maneuver. So the patient is grasped from behind and compressions are given on the xiphy sternum so that it displaces the foreign body and you can get the foreign body out. So this is done only when it is choking the airway and it is a partial obstruction, not for a foreign body causing complete obstruction of the airway. So if it is causing partial obstruction of the airway, then only you can do a Heimlich's maneuver. So the key trick to solve this question is see, is this in the black zone or is it in the gray zone? Black zone means airway, gray zone means digestive. If it is in the digestive, obviously you will do a esophagoscopy. If it is in the airway, then comes the question of bronchoscopy or Heimlich's maneuver or tracheostomy. Then that would be your options. So let's go to the next one. What is the sensory nerve supply of the larynx above the level of vocal cords? Internal laryngeal nerve, external laryngeal nerve, recurrent laryngeal nerve, or the superior laryngeal nerve? I think this is a very easy question, and always we have seen that questions come from the nerve supply of the larynx. So it's not something that's very difficult. It's a very easy question. Yes, so let us understand the nerve supply of the larynx. So let us take this as our mandible, and below that we have the clavicle. Okay. So in the neck we have the hyoid bone which is present superiorly. Below that we have the thyroid cartilage. Below the thyroid cartilage we have the cricoid cartilage. And this cricoid cartilage continues as trachea. Okay. Now we have the vagus nerve. The vagus nerve comes to the neck. It divides into a branch called as the superior laryngeal nerve. This superior laryngeal nerve divides into two branches. One going and piercing the thyrohyoid membrane and supplying the sensory nerve supply to the larynx above the level of vocal cord, which is your internal laryngeal nerve, and the other nerve going and supplying a muscle here which is present between the cricoid and the thyroid, which is your cricothyroid muscle. So this nerve that is sensory above the level of vocal cord is your internal laryngeal nerve. The nerve that is motor to the cricothyroid is your external laryngeal nerve. Now this vagus nerve continues down into the neck and at the level of subclavian artery on the right side. So we have the subclavian artery on the right side. What happens? It gives rise to a branch. This branch is your recurrent laryngeal nerve. So it winds around the subclavian artery and goes and supplies the larynx below the level of vocal cord. So recurrent laryngeal nerve supplies below the level of vocal cords and it is motor to all the muscles of the larynx except cricothyroid. So recurrent laryngeal nerve supplies below the level of vocal cords except cricothyroid. So this is the course on the right side. On the left side, the recurrent laryngeal nerve is given off from the vagus nerve at the level of arch of aorta. So it winds around the arch of aorta, enters the tracheoesophageal groove and supplies to the larynx sensory below the level of vocal cords. So sensory below the level of vocal cords, and it is motor to all muscles of the larynx. And it is motor to all the muscles of the larynx except cricothyroid. So now that you know the innervation of the larynx, it's very easy. Sensory nerve supply of the larynx above the level of vocal cords is internal laryngeal nerve. Below the level of vocal cords is your recurrent laryngeal nerve. And all the muscles are supplied by recurrent laryngeal nerve except cricothyroid. Cricothyroid is supplied by external branch of superior laryngeal nerve. Now let's go to the next question. What is the function of utricle and saccule in the inner ear? Is it responsible for both linear motion and angular motion? Only linear motion helps in hearing low frequency hearing loss, hearing sound, or helps in hearing high frequency sound. What is your answer? So for this question, I have given an explanation in the form of a short, animation. But before we go to the animation, I would just like to explain to you the function of your inner ear. So basically, when we take the structure of the inner ear, we have a central chamber called as the vestibule. In the vestibule, we have a spherical recess and we have an elliptical recess. So the spherical recess contains saccule. Elliptical recess contains the utricle. Now we have the semicircular canals or the ducts opening into the utricle. So the ducts of the semicircular canal open into the utricle. The receptors which are present in the utricle and saccule are called as macula. So the receptors that are present are called as macula. What is the function of this macula? They're responsible for all the functions of balance, whether it is linear motion, whether it is position of head against gravity, whether it is static equilibrium. For all the functions of balance, we have the macula, except one function, which is angular motion. Angular motion is the function of the crista. These crista are present in the ampulated end of the semicircular canal, and that's the function of crista. Okay. So Ikra Lone says that there was a question on coin that the child is stable, and then option was emergency bronchoscopy, emergency esophagoscopy, or Hamlet's maneuver. Yes, I think it is emergency esophagoscopy because the foreign body is impacted in the cricopharyngeal sphincter. So you have to do esophagoscopy and get the foreign body out. Okay, so let us understand quickly the vestibular pathway. So we know the inner ear has the saccule, it has the utricle, 3 semicircular canals, the posterior, superior and the lateral semicircular canal. The impulses from this is carried via the vestibular nerve, superior and inferior vestibular nerve, to the vestibular nerve. Okay, now the impulses from the superior canal, lateral canal and utricle go via superior vestibular nerve, whereas from the saccule and posterior canal via the inferior vestibular nerve. From there, the impulses will go to the vestibular nucleus. From the vestibular nucleus, it will go to the medial longitudinal fasciculus, where we have 3rd, 4th and 6th nerve nucleus, and it causes movement in the eyeball, which we call it as nystagmus. So vestibular stimulation causing ocular reflex or nystagmus, we call this as vestibulo-ocular reflex. So this could be your question in the next examination, having them asked question about the function of the utricle and saccule. You can have a question on the vestibular pathway, which is why I thought I should mention it here. Okay, now let's go to the next question. Identify the image and the arrow marked in the image. Sphenoid sinus, ethmoid sinus, maxillary sinus, or the frontal sinus. What do you think is the sinus? I think this is a lollipop, simple, easiest question possible, and I think there should be no doubt on this. This is one of the commonest sinus. Even if you don't know anything, you should be able to answer this. The sinus that lies below the orbit, on the sides of the nose, in the cheeks, is nothing but your maxillary sinus. The sinuses that lie near the medial wall of the orbit, these are your ethmoid sinuses. And then superiorly you will have the frontal sinus. Okay, and the posterior most sinus below the brain is called as sphenoid sinus. Okay, so hello Harshal. Let's go to the next question. A 35-year-old female takes a tablet of aspirin for her headache. Later she presented with wheezing and breathlessness. These symptoms are most likely due to which of the following? IgE release, nasal polyp, drug interaction, or extrinsic asthma. So I think this also is very easy question and a very commonly repeated topic. This question asks you to indirectly think about a condition which we commonly discuss in our classes, which is your Samter's triad. So what is Samter's triad? Samter's triad consists of nasal polyps, asthma, nasal polyps, asthma, and aspirin sensitivity. So they are sensitive to aspirin. So I always tell in my classes that a patient with nasal polyp should always say na to aspirin. No to aspirin is what they should tell. A patient with nasal polyp, what should they say? Always na 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 na. मुझे नहीं चाहिए aspirin. Na for what? For aspirin, because they are sensitive to aspirin that can provoke asthma. So this question should provoke you that after aspirin, wheezing and breathlessness is because of nasal polyp, because this is a part of the Samter's triad, and this Samter's triad consists of nasal polyp. Drug interaction with one tablet causing breathlessness and wheezing is not possible unless the patient is having a syndrome like Samter's. Extrinsic asthma should have features that the patient got exposed to pollen or animal dander or maybe some pollutant, something exposure is there, after that the patient develops, so then it becomes extrinsic asthma. Okay. So Harish, you're asking me about Haller cell and Onodi cell. Okay, so I will do that in the end of the class. Let's do the next question. A patient who's a teacher by profession presented to the clinic with complaints of hoarseness of voice. What is the possible diagnosis in this patient? Vocal polyp, vocal nodule, vocal cyst, or Rinke's edema? So I think this is a very easy question which I'm sure most students would know by now. Whenever we talk about a teacher, a singer, a hawker, where there is an excessive voice abuse, we know that excessive voice abuse is responsible for one very important condition which we call it as vocal nodule. So vocal nodule occurs because of excessive voice abuse. These are typically seen in the junction of anterior 2/3 and posterior 1/3 of the vocal cord. So if we take this as the vocal cord, this at the junction of anterior 1/3 and posterior 2/3. So at the junction of anterior 1/3 and posterior 2/3, you will see they are bilateral lesion, they are symmetrical lesion, and they are seen at the junction of anterior 1/3 and posterior 2/3. A vocal polyp also will be present at the same location. So vocal polyp is also seen at the same location. So nodule or a polyp would be seen at the same location because that's the point of maximum vibration and trauma. So that will be seen at the same location, but vocal polyp is typically unilateral and single lesion. Okay, nodules are usually sessile, whereas polyps are usually pedunculated. Okay, so nodules are usually sessile, polyps are usually pedunculated. Nodules occur because of chronic voice abuse, whereas polyps occur because of sudden voice abuse. So this is the basic difference between the nodule and the polyp. Okay, I think there was a question mentioning anterior 1/3, posterior 2/3. So I think it's very clear that the nodular polyp is present at the junction of anterior 1/3 and posterior 2/3. So this is an image showing you a vocal cord cyst, and this bilateral fusiform swelling at the anterior 2/3 of the vocal cord in the membranous portion of the vocal cord is your Rinke's edema. So anterior 2/3 in the membranous portion is your Rinke's edema. We have a question on Rinke's edema, so I'll be discussing the rest of the topic there. But meanwhile, I think this you should be able to differentiate the images of a nodule versus polyp versus a cyst versus Rinke's edema. Okay. Let's do the next one. A 25-year-old female came with the complaints of decrease in hearing, pulsatile tinnitus, tympanic membrane appeared red and bulging. What would be the diagnosis? Glomus tumor, serous otitis media, acute otitis media, chronic otitis media. Now this is something that is very directly you should be able to get to the answer on listening to one very important point. Whenever you hear the word pulsatile tinnitus resembling the heartbeat, the lub-dub sound that you hear, if you get this word pulsatile tinnitus, we always say pulsatile tinnitus is a feature of a condition which is glomus. So pulsatile tinnitus answer will always be glomus. Pulsatile otorrhea is different. Pulsatile otorrhea is seen in patients who have got ASOM and mastoiditis. So pulsatile otorrhea is a feature of ASOM or mastoiditis. It is seen in both the conditions, but pulsatile tinnitus is seen only in patients with glomus. Glomus, SOM, AOM, COM, all of them will present to you with decreased hearing. In acute otitis media, the tympanic membrane may still appear red, but the diagnosis is established here clearly on the basis of one single point, and that one single point is pulsatile tinnitus. So if you see pulsatile tinnitus as the statement in your question, please don't think of anything else, mark glomus. So in glomus you can see a red bulging tympanic membrane like this. Typically the appearance when it comes from the floor, if we see this red bulging from the floor, which happens in glomus jugulaire, we call that sign as rising sun appearance. So that sign is called as rising sun appearance. There are many signs in glomus. We have got the Brown sign, we have Aquino sign, we have Phelps sign, but the clinical examination sign that we see is the rising sun appearance seen in glomus jugulaire. A glomus tympanicum would produce something like this, a red bulging tympanic membrane. Okay, let's go to the next one. Which type of tracheostomy tube is used in a case of ICU patient? A metallic tube, a cuffed tube, an uncuffed tube, or a fenestrated cuffless tube? What is used in an ICU patient? So when we are talking of a ICU patient who is requiring tracheostomy, we know that this patient will require prolonged ventilation. So we know that this patient is going to require prolonged ventilation. He is going to be on a ventilator, and that is why we are doing the ICU and keeping him, that is why we are doing a tracheostomy and keeping him in the ICU. So when we want prolonged ventilation, there are two things that we want to be very sure of. One is no aspiration. We do not want any amount of aspiration to happen, whether it is saliva or our normal secretions, we don't want. The second thing that we do not want is air leak around the tube, because then the ventilator will have to work too much to give the tidal volume to the lungs. So we don't want air leak, we don't want aspiration. Both of these are served, or the purpose is served, by a cuffed tracheostomy tube. If you have an uncuffed tube, the air will leak, aspiration can occur. If you have a fenestrated tube, which we usually use for voice production, again there will be an air leak. Hence we do not use them for a ICU patient. It is used only in times of weaning from the tracheostomy tube, or if we are planning decannulation. Otherwise we always use a cuffed tube. Very good, Veer, you are right. So this is how the tubes look like. The first tube is your metallic tube. So this metallic tube is typically used in patients who require a permanent tracheostomy, like post laryngectomy, a patient is on permanent tracheostomy. Now this patient can't afford to keep changing the tubes again and again. A metallic tube comes in 50 rupees. He can buy, he can wash, he can clean, he can sanitize, reuse. So this tube is used for patients who require lifelong tracheostomy for breathing, and the purpose is not for aspiration but only for breathing. Cuffed tube is usually the one that you use in ICU patients, and I have discussed that. Fenestrated tubes will have a hole like this. This hole will allow the air to go from the tube to the vocal cords. So if there is a patient who wants to speak while on a tracheostomy tube, then you will give this fenestrated tube. So fenestrated tubes are typically used whenever a patient wants voice. So for voice production, you are going to use a fenestrated tube. Let's go to the next question then. A patient with Rinke's edema will have which of the following symptoms? Dysphagia to solids more than liquids, dysphagia to liquids more than solids, diplophonia or dysphonia. Now we've just seen Rinke's edema. We have understood what is Rinke's edema and how does it look like clinically. So basically Rinke's edema is the edema of the subepithelial space. So if we take the vocal cord, you will see there are 4 layers in the vocal cord. The first layer is the epithelial layer, the second layer is superficial lamina propria, the third one is the vocal ligament, and the fourth one is the vocalis muscle. Now the space that is present here between the epithelium and the superficial lamina propria, this space is called as Rinke's space. So the space between the epithelium and the superficial lamina propria is called as Rinke's space. Now here if we have accumulation of edematous tissue, myxomatous tissue, then we call it as Rinke's edema. So smoking, reflux, excessive voice abuse, any irritants can cause Rinke's edema, but the hallmark feature of a patient with Rinke's edema is diplophonia, meaning they have dual voice frequencies. It look like as though the patient is talking double. So that dual voice frequency is the hallmark feature of Rinke's edema. They can have dysphonia, hoarseness of voice, but the characteristic feature that puts Rinke's edema apart from rest of the other vocal pathology is diplophonia. Diplophonia is a feature that you see in Rinke's edema. Now dysphagia cannot be a feature because this is a laryngeal pathology. It has nothing to do with hypopharynx or the esophagus, nothing to do with your digestive tract at all. So no question of dysphagia. They will only present to you with diplophonia. Okay. Lacrimal sac is present in which wall of the orbit? Medial wall, lateral wall, roof, or the floor? Where do you get lacrimal sac? This is again a very easy question, but a little bit of confusion can happen in the examination. So think about it and answer. So when we say about the lacrimal sac, we know that the lacrimal sac is present near the medial wall of the orbit. Okay, so if you see here, if this is the eye, this is the roof of the orbit. So this is the roof of the orbit, this is the floor of the orbit, this is your medial wall, and this is your lateral wall. So lacrimal gland is present at the junction of lateral wall and roof, whereas lacrimal sac is present on the medial wall. The nasolacrimal duct goes and opens in the lateral wall of the nose. So nasolacrimal duct opens in the lateral wall of the nose in the inferior meatus. So nasolacrimal duct opens in the inferior meatus of the nose. Okay, I hope you got it. So we have the lacrimal sac, which is formed by the upper canaliculus, lower canaliculus. They join to form the common canaliculus. This open into the lacrimal sac. From the lacrimal sac you have the nasolacrimal duct. This nasolacrimal duct opens in the inferior meatus of the nose. Let's go to the next question. In a patient with Ramsay-Hunt syndrome, which ganglion is affected? geniculate ganglion, otic ganglion, trigeminal ganglion, or basal ganglion? Now again, this is a very easy question. I think Ramsay-Hunt syndrome came into popularity after a very well-known celebrity got it. Yes, I am sure all of you know it. Justin Bieber syndrome. So typically in the last few months, this has gained a lot of popularity on social media as well. So Ramsay-Hunt syndrome is nothing but herpes zoster oticus. So this herpes zoster virus goes and remains latent in the geniculate ganglion of the facial nerve. And whenever there is a, immunosuppression of the patient, that time there will be reactivation of the virus, and that can cause vesicles in the area of distribution of the facial nerve. So you will see vesicles. Along with that, you will see element type of facial palsy, and the patient can have sensory neural hearing loss. So this thing is very specific for Ramsay-Hunt syndrome, which is also called as herpes zoster oticus, which affects the geniculate ganglion. Now again, this question is very expected question because there was a surge. We have seen in the last 2 years questions coming on mucormycosis. So this was something that was expected to come. So let's answer this question. In view of mucormycosis, which of the following option has the least possible cause? Uncontrolled diabetes without ketoacidosis, broad spectrum antibiotics, neutropenia, prolonged use of steroids. So which possible cause? So whenever we talk about mucormycosis, what is mucormycosis? It is an invasive fungal infection. It is not a non-invasive, but it is an invasive fungal infection that you see typically in patients who are immunosuppressed and who are who are diabetic, which is uncontrolled, with or without ketoacidosis. It can occur in uncontrolled diabetes. It occurs on those patients who are taking steroids, on those patients in whom there is immunosuppression because of a COVID-19 infection, who are on who have undergone transplant. So these are all the patients who are susceptible. So prolonged use of steroid, neutropenia, diabetes are definitively a condition where the immunity of the patient is suppressed. So these are immunosuppressive conditions where there is a very high risk of acquiring invasive fungal infection. But we know very clearly that antibiotics have no role in suppressing our immunity. So why should broad spectrum antibiotics cause mucormycosis? No, broad spectrum antibiotics have got no role in causing mucormycosis, but diabetes, neutropenia and steroids do have a definite role in causing mucormycosis. Other conditions like COVID-19 infection, transplant, all these are other causes that can predispose to mucormycosis. Now they can also ask you for mucormycosis, what is the drug of choice? Because this can be asked. It is amphotericin B, that is the drug of choice. So for mucormycosis, amphotericin B is the drug of choice. Typically you will choose a liposomal form because it is going to cause less nephrotoxicity. And you have to definitely debride all that dead tissue. Okay, so we have another question coming up. A patient presents with complaints of unilateral nasal obstruction associated with watery nasal discharge or nasal bleeding, and the diagnosis of inverted papilloma is made. Which is true regarding the following condition? Is it malignant? Is it benign and non-invasive? Benign and invasive? None of the above. Very good, Sanjeev, you are right. Liposomal amphotericin B is the drug of choice, and you are right. So this condition, I think you should be able to answer. Unilateral nasal obstruction presenting to you with blood-stained nasal discharge or nasal bleeding, and inverted papilloma diagnosis is made, has already been told to you. So when we talk about inverted papilloma, again it is a benign condition, but it has a propensity to transform into malignancy. It is benign, but it is pre-malignant. It can always transform into malignancy. This pre-malignant or a benign condition is a locally invasive condition. This is a locally invasive condition. As the name suggests, inverted papilloma. It has got finger-like projections on the surface. You can see projections on the surface with blood-stained nasal discharge, and typically on histopathology you will see that the papilla will grow towards the stroma, not towards the surface. They are not growing outwards, they are growing inwards. That is why the name is given inverted papilloma. It is also called as Ringer's tumor. It is also called as transitional cell papilloma. It is also called as Schneiderian papilloma. These are all different names given to the same condition, inverted papilloma. Since it is a pre-malignant condition, you have to make sure that you excise it completely. So the surgery that you do is called as medial maxillectomy. So the surgery that you do is called as medial maxillectomy. It originates from the lateral wall of the nose. So you remove the lateral wall along with the medial wall of the maxilla. You can do with an external approach or an endoscopic approach, but the whole process that we do is remove the medial wall of the maxilla and the lateral wall of the nose. This is called as medial. Yes, Revanch, it is called as cerebriform approach. Cerebriform appearance. Okay. So this completes the ENT questions. I think they were very easy questions and not very difficult. The topics were always discussed in the classes, and I'm sure that confident that all of you would have done really well. Even if you did some silly mistakes, it's okay. Don't panic about it right now. There is always a chance that you must have covered those mistakes elsewhere and you could have gotten extra marks from there. It's okay. Whatever is done is done. Just forget about it at this point of time. What you got to focus at this point of time is just relax and have some fun. You worked hard, you gave your examination, you did the best you could, and now is the time. Just have faith in yourself, have faith in the Almighty, and just hope for the best. Okay, so with this I'll just tell you what are the features of the elite pack that PrepLadder is coming up with. We are going to have updated new video lectures of all 19 subjects. We are going to have next edition QBank, which covers 70% of the clinical questions. We are going to have notes that are in line with our video lectures. We are going to have treasures, rapid revision, mock tests, and past year MCQs in both video and test format. So this is the elite pack that is coming up for all students. Please do look out for my videos, which are going to be available from 1st of March. I have already started recording. I have just shown you a peek of one animation that I have done recently in my anatomy of the vestibular system that I have shown you, and the vestibular pathway that I have shown you, so that your understanding becomes very clear. I am trying to simplify the subject as much as possible so that the understanding becomes better, and when you understand something, your ability to reproduce becomes better. Okay, so with this I'll take your leave. Please do subscribe for the elite plan that's there, and pre-booking starts